Buenas tardes a todos. De nuevo estamos aquí en el espacio SILAN. Hoy vamos a tener el placer de disfrutar con la presentación de Daniel Rüfenacht y con los panelistas Fernando Viñuela, como siempre que nos acompaña, Juan Cebral y Leopoldo Guimaraens. Voy a cederle la palabra a Pedro para que nos haga una presentación sobre Daniel y los moderadores un poquito más amplia. Cuando quieras, Pedro, por favor.
Hola a todos, gracias Manel. Es un placer nuevamente estar aquí en el espacio SILAN de todos los viernes, mantenidos a pesar del COVID. Me alegra de verlos a todos bien. Daniel es un viejo amigo de la casa, ha formado muchos latinos, muchos hemos pasado un tiempo con él. Y realmente el tema de hoy es un tema que nos preocupa a todos nosotros, es el tema de la ruptura neurismática. Tenemos distinguidos panelistas. Está Fernando con nosotros, el doctor Fernando Viñuela. Está Juan Cebral, que dedicó mucho tiempo al estudio también del origen, del crecimiento, de la ruptura, del punto del CFD al problema que nos aqueja hoy. Así que creo que va a ser una jornada extremadamente productiva. Daniel, como ustedes saben, el doctor Rüfenacht, conocimos muchos de nosotros en Ginebra, durante su estadía en la Universidad de Ginebra, en el cual todos tuvimos la suerte de derrotar de alguna forma. Y este tema es un tema que lo preocupa de hace mucho tiempo, el origen, el crecimiento y la ruptura aneurismática. Y mucho tiempo ha pasado desde que juntos originamos, a raíz de esta preocupación, el Intracranial Stent Meeting, que en su origen dio... uno de sus orígenes fue esto, tratar de ver cómo podíamos ayudar a desentrañar la ruptura. Así que hoy mucho tiempo ha pasado, hay muchos nuevos conocimientos y es un placer para nosotros presentarlo a Daniel desde su nuevo lugar en Suiza, en su Suiza natal. Él nació en Berna, pero ahora se encuentra en Zurich. Así que thank you, Daniel, for being with us. This is a very interesting topic. We have a distinguished panel of panelists with us. Juan is there, Fernando is there, and Polo is there also. So, no sé si, Polo, querés decir algo acerca de tu amigo Daniel Rüfenacht, o pasamos directamente con Daniel y luego seguimos con el panel. Polo, ¿estás ahí? Bueno, vamos derecho entonces con Daniel. Are you ready with...
Yes.
To go ahead, please. Thank you for being with SILAN.
Well, thank you all for inviting me to speak. And unfortunately, my Spanish has not improved, but and my English still sounds like a Swiss English. But I hope you will get along with me for a few minutes. And the topic I did choose after Pedro asked me to join this webinar sessions from SILAN is I wanted to speak not just about science, but the way we counsel patients. And the reason I do that, I thought there may be younger listeners to this, and I observe in my environment that too many people make patients afraid of rupture, an event that is very difficult to capture, and then patients get too much afraid, and they may want to get treatment without need. You may remember that when we started Aneurysm, actually in Buenos Aires, at the meeting in 2005 in Buenos Aires, we were talking about, and then 2006 it started. The goal was to make sure that we don't overtreat patients, and this is maybe something we have reached now, and I would like to share about this. One of the persons that has continued to accompany me is a neurosurgeon, Philippe Bischlenga, from University of Geneva, where I have been professor until 2008. And now, as you have heard, I work with Isabel at Hirslanden Zurich, and we have created this Swiss Clinical Neuroscience Institute. And with Philippe Bischlenga, we had more financial support for research, and we are entering now a phase of genetics around aneurysms, and I think this is a new door to open. Since 2006 until now, I was very happy to get along these people that are really smart, like Juan Cebral, and engineers that understand the physics around aneurysm and flow. So I thought it's time to enter and show the people how we have learned in the last 30 years along the development of all these options we have to understand and treat aneurysms. And maybe one of the things I want to insist is that the more we learn, it has to do with inflammation of the vessel wall. When we talk about stability of the aneurysm, and it's, I think, key to improve our understanding on how inflammation of the vessel wall interacts with the aneurysm wall. A little small aneurysm can be a healthy scar without any risk to further deteriorate, but some patients will see an inflammation occur in this aneurysm, and then we enter an instability and growth of the aneurysm. So this is what I would like to talk about. I speak to you from, let me see, from Zurich, and I see that the connection is well, and I'm happy that this works well for you. I have made a little, or we have made a little summary. You can look this up going on the internet, and you should find there. Otherwise, if it's not yet there, in a few days, it will be certainly there. Now, if you go to like an institute like the Aneurysm Foundation, Brain Aneurysm Foundation, you will see all the details patients read when they hear or learn that they have an aneurysm. And they are very scared when they read this, and it's rupture, death, and, all these things. What it doesn't say on if there are 500,000 deaths worldwide, I don't know if this is true, but this is what they say, and I assume that they're quite well. And 50% are the fatalities of the ruptured brain aneurysm. So there are 1 million ruptured aneurysms in the world. Then there are 300 million aneurysms walking around. So it can't be that we make this 299 million aneurysm people afraid with this, just with these facts. And we need to better understand how this disease works and how we can explain to them when to treat and what they should know and learn about these aneurysms. So I show you this little summary on how things have evolved it doesn't go forward here. This is the timeline, and maybe it's very, not very fine, but you see that every 10 years we could see quite, significant development in engineering, in devices, but also in the understanding. And the understanding clearly has improved from a little thing that has a certain size to a living thing that has a wall, and this wall is not a homogeneous thing, and it can change over time. So really what we have seen is that the concepts on how aneurysms grow and how they behave and the life cycle of aneurysms are something that we ought to better understand, so we can better decide and we can better counsel patients. And I think this is an important step, that we translate our knowledge to our patients, and we don't make them just afraid, but we use the engineering and the progress we see along, and that this progress we can translate to knowledge and information for patients to make them, to assure them that they are not more afraid, but that they better understand their disease. With the aneurysm, we wanted to essentially, the aneurysm project, we wanted to have at least the number of patients treated, because we thought at these times with MR, we see more and more incidental aneurysms, and we need to understand when to treat and when not to treat. And one of the problems we saw with the ISOIA study when it came in the 90s, that everybody was talking, yeah, we have seen many small aneurysms ruptured, but then the study said, well, we shouldn't treat them if they are smaller than 7 millimeters. And we all had big discussions. We lost time just on fighting on stupid things, I think. But what we could see is in an overview, like from Bruce Weyer, that most of the aneurysms we see rupturing are small. So this was giving us a problem in how to make a good interpretation of this situation. And I made here, this is just a cartoon, but you see that obviously since aneurysms grow, they are not born just big, they grow. Most of the aneurysms are small, and then they grow and they grow, and but only a few are very big. And along this growth, there is an incidence of rupture, and obviously this seems to go bigger with bigger aneurysms. And if you look the proportion of this rupture population, obviously we have many more small aneurysms ruptured than the proportion in ruptured aneurysm in larger sizes. So it's clear that even with a small incidence, we have more small aneurysms that have ruptured than big aneurysms that have ruptured, because the sheer number of aneurysms is bigger, and that's why we see this happen. And this is, I think, the easiest explanation I find to make people understand this is a relative number. And I also bear with Bruce Weyer, who analyzed all these events around an aneurysm, and clearly he looked at the inside, the outside, and the wall. And we started to learn on how different elements of the life cycle in an aneurysm are influenced. And obviously with the advent of flow analysis, we start to understand much more about the inside and the flow. And we try to explain and understand the interaction with the wall and the biology of the wall. However, we all understand today that the driver of the biology is the flow, and the biology, however, is different in every patient, because to the same energy exposure, not every patient will develop the same type of reaction. And that's why it's very difficult to be sure that if we make a flow analysis only to understand what the biology of the wall does make in an individual patient. So for me, over time, it became clear that we should look at the wall as good as we can, and we should use all the information we have on the wall. And for us, the best instrument to do so is the 3 Tesla unit MR with contrast, and gives us an insight on the aspects of an aneurysm, and we translate them to the behavior of an aneurysm. Obviously, there is much more to it, and we consider like all these different scores, smoking, hypertension, and female, male, age. So all these things we kind of have learned for many years. And but what I think is difficult to then use is the statistics only, because this does not allow really for an assessment in a personalized way. And therefore we keep all these scores in mind, but we trust much more to what we can see in MR. And we tried also to improve this by doing this Delphi type of assessment as a multidisciplinary consensus, because this is modern, and I think this we should all do, to find in a multidisciplinary way and discuss each case, so we don't miss to treat or overtreat patients. So I think this is also an important part of our decision making. Now, the way we have learned over these few years is that, yes, the concept, there is an initiation, and then there may be a scar and stays like this, but it may grow. And the more it grows, the more there is risk of developing an instability. And with instability, what we observe is that there is usually inflammation, there is some clot, there is irregular shape. And the more it's unstable, the more we see an increased risk of rupture. But here in the big numbers, there are many, many stable aneurysms that do not need to get treatment. So the way we look at this is we kind of don't talk too much about the rupture, since this is a little event and it's difficult to make people and patients understand the statistics. We better tell them, yes, if it's unstable, we should treat, but if it's stable, we are allowed to observe, and we may be doing good. So we kind of make a guarantee over a short period of time, observe, and then bring him back or her back, and then we test again. And so this activity builds up trust in us and helps us to make patients understand that we don't want just to get their money out of the pocket for treatment, but we care for them. And we, I think, have become, through this over the last 5-6 years, a good place to, have people join us and get explanations. So avoiding talking about the rupture risk and the rupture, but understanding and make people understand that this is living tissue, it may be stable, and we may not need to treat, has been a very good experience for our group. And I think this is what I want to relay to you, because this is, I feel, a good experience. The background of the knowledge of this instability is clearly mainly due to the activities in Helsinki, and Johanna Frösen, one of the youngsters in Helsinki, has done a great job, and he has helped to connect many people to their activity. And what we can see is we have a roadmap on how we could imagine the biology of the aneurysm wall, maybe a little different from just a regular vessel wall, but very similar, and how this leads to instability. And obviously, if something is unstable, the risk is rupture, but it's very difficult to say here is going to be an accident in 5 minutes. And I think no simulations, and especially simulations as we have today, that don't consider rupture, and all this complex system pressure, all the complexity around rupture can really simulate the rupture. But what it is excellent for is, I think, to get us a better understanding on how the process of biological stimulations through flow has interaction with the wall and how things evolve. And I hope that this, CFD community sticks with us and helps us to make better understanding of the disease, but also better devices and maybe device regulations. But I think all what we kind of say about rupture is a very difficult thing to foresee, to plan. And I compare it easily with car control. If you check your car and everything is okay, then you can continue to drive. well, but an accident and foresee accidents and statistics of accidents don't really help to understand if your car is going to have an accident in the next 1 year or not. So I believe really we should avoid troubling patients with this discussion. And what is now stable? Stable is if the tissue is still maybe is degraded, is a scar, is not anymore a normal muscle. There may have been disappearance of endothelial layer. Usually there is some, but you know, this is not anymore in the same amount of workers replacing and curing the wall, but it may be stable. Whereas if we have thrombus and all the related changes and biological mechanisms that lead to inflammation, then we may see a rupture. And translating it to our 3 Tesla MR is, if you observe over time, if it's getting bigger, then we think it is unstable. If the shape is irregular, then we also believe there is a sign of instability. And if there is enhancement, and there is quite a few papers about enhancement, there may be clot, there may be slow flow, there may be inflammation in the wall, but all together doesn't really matter what really is occurring. If we see enhancement in the wall, if it's not a scar formation after treatment, if it's an untreated aneurysm, I think we need to worry about instability of the wall. And we better use these signs alone or better in combination to decide for a patient to treat or not to treat. And I think this is obviously very complementary to what we have seen before about smoking, about blood pressure, about age, about, you know, all these we consider alone. But if we do an MR, 3 Tesla, nice picture, we can analyze in 10, 15 minutes. And then if we, based on these pictures, give an assessment to the patient, and at the same time, we ask them about other things, within 20, 25 minutes, there is a counseling where patients start to trust because they see what we are talking about. And I think this is very useful. So it's a useful tool to use these images to translate what we know about vessel and aneurysm wall biology, and I think this is what has been the most single useful thing I have observed in counseling patients in the last few years. And obviously we continue to, you know, in our heads, we continue to use all these cartoon implemented aspects of an aneurysm development, as you have seen in the cartoon of Bruce Weyer. And I think it's a very good cartoon, and it kind of holds all these different elements. And what we see is that some of the biology we can't capture right now directly may, you know, we may see in a genetic background analysis. So what we currently do with this aneurysm database research that is continuing from Aneurysm and is actually well entertained by our foundation and the University of Geneva. We have more and more genetic information about this, and we hope to be able to get more and more knowledge in a personalized way, because we all are individuals that are different, and this variation is true also for aneurysms. So this is the easy way. So regular shape and no signs of inflammation, no growth. For us, this is stable. And if 1 or 2 or 3 elements change, then this we would consider unstable, and then we get much more alert and we talk to the patients. And the first time we really saw it in our patients was, I think, in 2000, maybe 12 or so. I think this is, I'm sorry, I'm getting old. But you know, this is one of the first pictures in MR. We said, oh, wait a minute, this is something different here. It's not seen on TOF imaging here. And if we do some contrast imaging we see, and we thought this must be kind of clot or whatever. And at this time, what we see is that we think that this is the place where inflammation occurs. And after, later on, we kind of use this, and Isabel has made this cartoon, that we think that if there is inflammation in this part of a wall, that's where the wall may be ready to expand and may build a blister or a bleb. And this is exactly what we kind of continue to translate to our patients. So in this case, you could see that this part was in the low flow area. And I remember all the discussions we had with Juan, if this enhancement correlates to high flow or low flow, and we end up believing it may be both places that are exposed to not enough or too much stress, and that these are places where we will observe this inflammation in certain patients. This is a nice example where you see that there is obviously much more than the wall thickness, but maybe slow flow, but also maybe clot. And if you look at the reconstruction, we see that this is exactly where this aneurysm has expanded. And if we do imaging, we see that in contrast filling that this is slow flow in this area. So I think it's good to discuss and learn about, is it slow flow, is it clot, whatever. But obviously all of them actually may occur, and all of them are bad to the aneurysm wall. So instability doesn't matter what is really behind, but instability is indicated at least in most of these unruptured aneurysm when we see them. We use this sign in follow-up, and we have this 80, in 2017, she's 81, but we observe her since 2006. And it is a pericallosal aneurysm that stays the same. All is the same, no enhancement. Meanwhile, we have black blood imaging where we see the vessel wall. In 2016, so 10 years after, it's still the same. And a year later, we see that the aneurysm has changed, has enhancement, and also she's 81, we decide to treat her. And this is the way we do. So what you see is that if we have instability, it may occur over time, and it may not be that we can give a guarantee forever. And I think one of the reasons that things may change is that flow changes over time, maybe blood pressure changes. And I like to use this slide from Juan where he made all these different options and opportunities that may lead to a rupture. I believe he should say stable, unstable, and actually rupture. You know, what I always miss here, there is no pressure, but if there is no pressure, there is no rupture. So I think we still have a problem to go if we want to do rupture prediction by simulation alone. And I think the tool is much better to understand stability and instability, because it's having a good assessment of the driving forces of the biology of the vessel wall, that is shear. But when it comes to pressure, it has to involve also, I think, rupture. It has to involve pressure, and I think there is room to, this continued discussion if we want to do simulation of rupture. I think they have done a definitively good paper, and if you want to learn about this inflammation, degenerate changes of the aneurysm wall, Juan Cebral, here he is, and Joanna Frös, and I think this is a good paper to read and learn about this interaction of flow and biology. I think I need to hurry a little bit because I speak too slow, but I think this is another good paper to have a look at, because arteriosclerosis is considered to be an unresolved inflammatory condition. So it's a continuous process. It's not just like one time an inflammation and a finish. So it is interesting to learn about these concepts of inflammation in our body and how they interact with different organ systems. Clearly, the endothelial layer is something that interacts very much with this unresolved inflammatory condition, and we should continue to look at this when it comes to maybe also medical treatment of stability or instability in aneurysm. And I think David Hassan has done a good job with looking at the influence of aspirin, and there may be clearly other options of anti-inflammatory activities through medication. Now, you know, I don't want to start explaining this, but this is a cartoon we made when we started to look at wherever there is action in an aneurysm, in a large aneurysm, before treatment, after treatment, and all this. And I think these are the biological processes we still can investigate more, and there is room to learn much more. And if we do that, there will be clearly more knowledge on how to influence this biology, but this is not the topic today. What I would like to almost start finishing this talk is doing this. About 50% of the incidental aneurysms we consider stable. So this is a good number. This is the number we wanted to achieve when we started out with aneurysm. And obviously this is still over-treating our population, but you know, if we only treat half, we have done a good job in saving money and making people less afraid of this disease. We also see that we should be aware that there may be over time 5 to 10% conversion that people become unstable. So we should not tell this is stable, finished, you can go. We need to continue to observe these patients. This is a chronic disease, and obviously this we should continue to do. So we should develop a continuous relationship to our patients, and actually these have been very rewarding in many cases for myself. You know, I think looking at the smallest part of our system is not only the nerve cells, but also the thinness of these vessels and the small vessels. And it's always amazing if we go to pathology to see how thin this wall is and how big the pressure is inside, and you know, all this. I think it's fascinating, and I really am grateful to the part or time I could be part of this community to, you know, start learning more about this, investigating more about this. And I continue to be, you know, really interested in this. Currently, we try to get involved more in the vascular part that makes aging. And we believe the thin wall of the small vessels is very involved in aging of the brain. The brain is only 1 to 2%, gets 15% of the heart production. So there is a big stress to all this vascular tree. And we continue to support as a group, obviously the ICS this year we will do because we think we should expand our view to not only aneurysm, but you know, since the CFD guys now can see more than just an aneurysm, they will do for us the whole AVM, and I hope this we will be able to have maybe a hybrid or a meeting over internet, and maybe at some time soon when COVID is governed in a different way, we can have a physical meeting again, and we would be very happy to welcome you back in Switzerland if possible. We also do this International Neurovascular Exploratory Workshop because we had, after aneurysm, a big support, again, thanks to big activity of the fungi, that we could learn more about integrative IT when it comes to certain diseases, and here it's aging of the brain. We believe that it's a very important thing because 15% of the people at my age and older That's the majority that get a surgery. 15 to 20% will have a delirium. We will have a problem after hospital stay. And we believe that this has to do with vessels too. So we will learn, and I think we will investigate in this direction. And I welcome you at any time to join this through this website. And we want to get visible like Canary and others on the internet for being good. And I try to summarize what I just told you when it comes to aneurysms here on this picture or PDF, and we will make it available either here or I don't know. I sent some copies to Pedro and he can distribute wherever he would like to. Thank you very much. I was a little bit too long, but I hope this is okay.
Thank you, Daniel. It was not too long. It was very interesting. We enjoy. Well, we have a distinguished panelist with us. I will be giving back to the word to the Manel. Manel is the actual president of the society. So, Manuel, si querés iniciar vos la discusión con los panelistas y con Daniel, ¿te parece?
Sí, perfecto, perfecto. Thank you, Daniel, for your very interesting presentation. Me gustaría que Fernando empezase a hacer un comentario desde el punto de vista general y luego pues Juan y Polo que comentasen sobre el tema, sobre todo Juan que hiciese algunos comentarios sobre los efectos hemodinámicos y la alteración del flujo en la pared. Me pareció muy interesante lo que aportaba sobre la determinación de los estudios en 3 teslas de la pared del aneurisma para valorar pues, el riesgo no de rotura, ¿no? Y el proceso inflamatorio, que de eso Fernando ya nos ha hablado un poco de las citoquinas y todo ese procedimiento. Fernando, cuando quieras, por favor.
Bueno, podrías volver a la etapa anterior para intercambiar conceptos, porque tengo todavía las imágenes que presentó Daniel. Tú podrías, ok. This is something that it comes from my heart, Daniel. Do you hear me?
Yes, yes.
I think you have defined a framework of investigation in which you have involved morphology, flow dynamics, and then you involve inflammation. Inflammation, in particularly inflammation in aneurysms. And then you show pictures of enhancement, and in which you interpret it as an element of an inflammatory response. I love to have a webinar with all of us in which we could talk about how the endothelium responds to damage and what kind of inflammatory responses it produces, because endothelium is always related to inflammatory and inflammation, either innate or adaptive. So to have an inflammatory response in an aneurysm is not surprising. But the concept is to identify, is it pro-inflammatory or is anti-inflammatory? You can have an inflammation which is acute, produced by inflammatory cytokines, or you can have a regenerative inflammation, which is healing, which is produced by anti-inflammatory cytokines. So inflammation in itself is not an element of abnormality, because since the beginning of the annular formation, there is an inflammation. The endothelium has mechanosensors. They show here, which stress produces damage of the mechanosensors. The endothelium is damaged. The flow is related to the media and this aneurysmal formation at form. So as an element that, and what I love to go and have a meeting among us to deeply analyze inflammation in endothelium, inflammation with leukocyte, endothelium with platelet inflammation, endothelium with coagulation inflammation. So what I'm saying, Danielle, that we need to destroy our isolation with today flow biomechanical and researchers, the so-called microphysiological research. This is what they show. When an inflammatory response, which is negative, is transformed into a regenerative response, with the macrophages that produces the inflammatory cytokines transform themselves into regenerative macrophages and produce anti-inflammatory cytokines. And as well, Daniel, today, if we look at what they do in tumors, how to identify cells in tumors, how we identify in a tumor vascularity, vascular cells, tumor cells, macrophages, etc. We can also bring these sciences to us. And inflammation itself, in itself, is something that you have to go deeper. It's another galactica. And I will suggest to you that in your next meetings, and yet you bring microphysiologists call, or organ in a chip, if you call, or whatever, to the meetings, so people involved understand the complexity of where we're aiming. I fully agree, Danielle, with you. This is a framework, but you have to go much deeper if we want to transform this into a translational research. Because now we cannot translate it because the knowledge that we have of inflammation and imaging, now you have nano imaging. You can identify macrophages, you can identify another cells, and by nano imaginology. So I really love your presentation. For me, your presentation is the platform to go much further, but we have to open the door to the so-called bioengineering and so-called microphysiology into our specialty, or we will continue that talking about inflammation with reality without knowing exactly what it means. Danielle, it's nothing personal. I'm just talking from my heart. This is a topic which I'm obsessed about it, and fortunately I'm involved in a Terasaki Institute in Los Angeles, which is an institute of biomolecular innovation, and I like to share what those people know. Thank you.
Thank you, Fernando. I like this comment. This is beyond of what I wanted to speak today, but I agree very much with you. In our community, we have access to DMMD, Department of Molecular Mechanisms of Diseases, and the head of this is Michael Hottiger. We work with him for now many years, and he told us about this NF-kappa-B stuff in the inflammation process in the aneurysm wall. But today, looking for brain aging, we go further to the mitochondrial level of energy supply. And I agree very much with you. This is where the things happen. We need to, like in tumor and other diseases, we need to get down to the cellular level and understand the molecular mechanisms to be better. But since we are young, you know, you and me are still young in this field. This field is only 30 years old. We are allowed to, you know, be a little bit behind, and the other guys will help us to be quicker. I think your institute should give us an insight, and we will do everything to bring what we learn here from about molecular mechanisms to our community. And I believe that the best group in this term has been long people in Helsinki, because they were capturing tissue we can't in our endovascular world. And we may be able to get to this level when we get instruments to study this level. But right now, I think with our instruments in imaging, the closest we get is maybe the MR imaging. I'm sorry.
No, I fully agree with you, Daniel, please. I fully agree with you. But it's important to bring this knowledge to see what is the challenge that we're dealing with.
Absolutely, yes. Thank you for this comment.
That's all, in a positive way. No, this is a perfect framework, Daniel, to take it to a meeting and to share how much we do not know and what we need to associate it with people who knows and inviting them to help us.
Yes.
Juan, escuchamos a vos, vemos a Juan que ha estado trabajando en el tema también un tiempo más que prudencial como panelista, así que somos todos oídos.
Gracias, Pedro. Thank you, Daniel, for your excellent talk. I always enjoy hearing your views. And I fully agree that we should be looking for signs of instability and things that may raise a flag that something bad is going to happen in the future. And so, one of the previous studies, or several previous studies, have used characteristics of aneurysms that are similar to those that have already ruptured as an indication of, if they are similar to the ones that ruptured, then you believe that this aneurysm may evolve in that abnormal way. So coming back to your analogy with the car that breaks down, yeah, if you see cars that have, bad connections in the valves or whatever, and then, well, those cars have been observed previously to rupture, right? So I think looking for any indications that predispose or place the aneurysm in a category in which many of those are known to have rupture already, I think it's a good approach. But we are all probably going after the same aim, right? To identify characteristics that point to events that in the future may destabilize or rupture or produce some sort of complication, right? So, so I fully agree with your observations, and many times we have just used the rupture point as the ultimate outcome because that's the only thing we had at that time. But I fully agree that, for example, looking at the wall enhancement may give us much more new information that is more closely related to the biology. But it's still, I think it's still in the infancy because we don't understand what the enhancement means and where it happens. You show some cases in which you have wall enhancement at the bleb of the aneurysm. But I was wondering, for example, do you believe that you can enhance a wall that is very thin? Because if you have a very thin wall, there's no place for the contrast to go in. And so you won't produce a very high signal in the region of very thin walls. And maybe thin walls are regions of the aneurysm that are very vulnerable. So I wonder if, that kind of imaging will help us to identify these very thin and very vulnerable walls. And of course, if you have a very thick wall with atherosclerotic remodeling and all the bad words, yeah, that's probably going to enhance. But is that the place where the aneurysm will rupture, right? Or so that's one question. Yeah.
Well, listen. In order to have an enhancement, you need an intima and a media. So you're right. If the area is very, very thin, which has only an endothelial lining and maybe a base membrane and maybe a very thin part, that area is non-inflammatory, is destructive. On the other hand, by the side, you have an inflammatory process in the area. So the endothelial damage produced a damage, but didn't produce damage to the intima, and that elicited a deposition because, you know, the shear stresses variations produces activities in the mechanosensors part of the endothelium, and the mechanosensor activated the smooth muscle cells underneath, and that produces responses. The responses is immunological responses. And they will depend, you know, we have seen aneurysms with aneurysm that have the other part is thick and the other part is thin, correct? So, and that is because the shear stress responded differently to the mechanosensors of the endothelium in those levels. The thinnest part is always, the thinnest part, if you can see, it is always the most dangerous part because there is no pro-inflammatory reaction trying to overcome the damage produced by the flow. Now, the inflammatory response can be pro-inflammatory or can be responsive for regeneration, and that is the area that will produce calcification or something. So enhancement itself showed that it's an activity. But nowadays, with immunofluorescence, and also I hope that in the immediate future with MRI, Daniel, we'll be able to identify, for example, macrophages and separate them into pro-inflammatory macrophages and anti-inflammatory macrophages. And there are anti-inflammatory macrophages where they say, oh, the enhancement is healing. Do I explain myself clear?
Yes, sure.
That's the way to go. That's the way to go.
Thank you, Fernando, to answer to Juan.
You know, sorry,
Juan, no, it's very good. It's very good because, you know, Juan, I think I didn't want to make the enhancement to be the key item. You understand? I think there are several items to look at, items we trust for many years, like size and shape. And in addition to this comes obviously also this enhancement. And I don't claim to understand all the different variations of enhancement, but if you observe aneurysms over time and then they change, in addition, they start enhancing, this is an alarming sign. And we have seen aneurysms we don't treat because they are, we assume, thick-walled, you know, typical location. Aneurysms with enhancement, we don't say this is really unstable because they stay for years or have been for years the same. There are also aneurysms we know that enhance after treatment, like Fernando was explaining before. There are different parts of pro and, you know, inflammation and good inflammation and bad inflammation. So I don't want to enter this arena. And I think this is worth a webinar or more than one, just like Fernando was saying. But you cannot escape me, Juan, because, you know, you have promised me that we will get an additional element of use in imaging that is, you know, this hostile hemodynamic environment prediction or assessment using TOF imaging. And I think this is one of the information your world can bring us, and it just doesn't happen yet. Why?
A good question. I think it's, well, at the beginning, we were very welcomed by all the neurosurgery and neuroradiology community, but, you know, years have passed and many people have doubts that that computational models can be predictive. And, you know, to tell you the truth, we had a prototype working with Philips in 2008 that was ready to be developed and, you know, and deployed to different sites. It was a working prototype of doing simulations in the Angio suite under their system. And for some reason, Philips decided to not prioritize that prototype and go with, you know, other commercial tools that people preferred. So we can, and at that time I asked many people why, what would be needed to convince the clinical community that this would be something useful. And I got an overwhelming answer saying that we need statistics to show that this can make a difference, that you can actually identify aneurysms that are prone to rupture. So we dedicated a few years after that to show that. And right now we have a database of about 3,000 aneurysms, and we have shown that yes, you can identify rupture aneurysms with an accuracy of about 84–85%. So now the key is, are people going to use this? And I don't know. So you have been promoting or trying to make us develop all of this, so maybe you can convince your colleagues that this is useful. Right? But I think we have been doing simulations for a long time, and we have shown that there are a lot of connections between the flow mechanics and the biology, the flow mechanics and what happens later on with the aneurysm wall and so on. So I think there is a lot of value scientifically as well as clinically. But so far, yes, we have not seen the translation of these technologies to the clinic. But I don't have a precise answer of why that hasn't happened.
Guys, we have some questions from the audience that I would like to start to answer if it's possible. Jose from Jerusalem, Jose Cohen, is asking you, Daniel, have you seen the reversal of vessel wall enhancement after controlling hypertension, discontinuing smoking, starting aspirin or statins? Have you seen that?
Well, we have seen too few to make statistics on this, and I think we need to see more, and I think we need to have a database of a larger population to be correlating this conversion to instability. But if I can answer, I think one of the driving forces in recurrence of aneurysms and by this instability is blood pressure. So I really believe we must make sure that patients that have a blood pressure increase after treatment or without treatment, we should make sure that they are getting antihypertensive treatment. Obviously, we should make them stop smoke. But I cannot answer reliably to Jose's question. I agree with him that likely these may be phenomena that influence this conversion. This old lady hasn't changed her lifestyle, and I think I can't give an answer in this lady I have shown you. So I'm sorry, I can't answer. But yes, basically I believe this is the driver.
Well, this is the
¿Puedo hacer un comentario?
to match and follow those patients very long, because they will get hypertension probably during his life. So this is the one of the part that we have to compare to think about it. There's another question from Reynaldo Ramirez. He's asking you when you follow the incidental aneurysm, when you decide embolize in the follow-up, what are the factors that make your mind go and treat that patient?
If there are several, but usually if an aneurysm starts to change, gets bigger, changes shape, starts having enhancement, then we kind of explain to the patient it may be better to treat. And what is amazing is that if you use these simple rules, that if you decide that this doesn't look like an unstable lesion, most of them will stay stable over time. And it builds trust over 6 months, over a year. If they're very nervous, we make another exam in 3 months. So if it doesn't change in 3 months, they start believing you, and then you build up trust. And we didn't have bad things happen. Only one lady, she converted, and we said, you should get treatment because there started to be an enhancement. She didn't want to get treatment, she ruptured. And so, yes, I think we should use this instrument to build trust to the patient, and we should be telling them if there is change that we should consider treatment. I think it's more difficult to decide sometimes if it's unstable at the beginning. And, you know, sometimes it's a little irregularity, or as Juan said, there may be some thick part and we don't think that this is really instability, but, you know, so to initially decide, we should consider it a stable lesion. But we only have one exam. This is very difficult. So the first time you take a risk, and that's why we may opt to short time follow-up. But as soon as we have engaged on the track of stability, we have been very successful in getting these patients to follow and trust us and not seen ruptures.
You know, there is another question which is related to what is the frequency and technique that you're using to follow up those incidental aneurysms less than 5 or less than 7 millimeters in size?
What we do is we obviously, you know, if we get an exam that has not a black blood, we get a black blood. We get a special sequence and protocol to standardize somewhat the evaluation. And once we have this, we have maybe a half-hour conversation, counseling of the patient. And in this counseling, we try to identify if they are very worried, and if they're worried, we try to build trust. And as soon as we get this and they follow our advice to, you know, stop smoking or whatever we consider, then depending, we will make a 3 months or 6 months follow-up, and maybe another one. And then if it's stable in a year, and usually we stay at a year, or if it's a very small aneurysm, it stays stable at 2-year interval, sometimes 3 year. But we build up this trust, and by bringing them back, they know we look after them. They start learning to know us, trusting us, and they know if there's anything, they would know where to call. So we have like a big backyard of apples, and we only harvest those that are ready and needed to harvest. And I think this is a good way to look after a chronic disease like aneurysm disease. I have seen that people or colleagues that only a good aneurysm is only one you have treated, you know, and this is a way that people make also afraid. And I think it's good to treat, but also it's good to learn not to treat when it's no need. And this builds trust in our view and understanding of the disease.
Daniel, ¿me oís?
Eduardo Bravo would like to know if you believe that the growing of the aneurysm are a linear function or the exponential function, the growing of the aneurysm.
Yeah, this is a very interesting question, and let me show you one slide just after this. Oh, you don't see any slide anymore, huh? It doesn't matter. You know, what I think is we have seen that very much, and what's her name? Robertson, you know, learning and teaching us about all this collagen. Collagen is in a way we form and ready to expand to a certain stretch, and after more it will rupture. And I think if we see in this cycle of collagen formation, there is you know, a certain time span, collagen gets ready to expand and then may expand to a bigger size. And this is what I think is happening in large aneurysms. So if we see large aneurysms grow, I think they stepwise grow, and maybe with an increased blood pressure or whatever. But this is when they become symptomatic, and that's when we see them grow like for a certain percentage, and there is a clot of a certain size inside of this partially or largely thrombosed aneurysm. And I think this is a stepwise process that is the allowance given by the tissue in the vessel wall. And this growth is maybe initially little, but in large aneurysm, it can be a significant growth at one time.
Polo quería hacer un comentario. Polo.
Daniel, salut Daniel, a todo el mundo. Pedro, Fernando, ¿cuánto tiempo? Nos vemos. Juan, una pregunta, une question, Daniel, en français.
Oui.
Si jamais tu avais un anévrisme, qu'est-ce que tu ferais? Le pregunto que si él tuviese un aneurisma, ¿qué haría? ¿Esperaría? ¿Seguiría? ¿Se hacía controles? ¿Cuál es tu respuesta?
I think I would
Quelle est ta réponse? Si jamais tu avais un anévrisme, toi, qu'est-ce que tu ferais?
I think can I answer in English, okay?
Yes, yes.
I think I would just behave the same way as I do with my patients. And I think today technology development is, I would get treatment with a good endovascular guy if there is need to get treatment. I think only few locations I would want to have surgery done. I would really go for endovascular treatment, but I would not get treatment if this aneurysm looks like a stable aneurysm. Yes.
Daniel,
So
I
really do the same for my patients as I would do for myself. Yes.
I have a question there as well, and we have probably been discussing this in the past, but suppose we are talking about the small aneurysms, right? That are the ones that we don't know what's happening. But most, let's say, don't you think that, I mean, all the aneurysms, all of them go through a phase of instability because all of them develop and grew,
Yes.
right? So if you're just by chance looking at them during their initial growth, you will see that they are growing, but maybe they later stabilize. So just seeing an aneurysm, especially the small ones, growing, is that a sign of true instability, or is just because you happen to see it when it was growing and all of them grow?
Yeah. Well, I think that's there are some very small aneurysms that immediately rupture, and this is we have no chance to predict. But as soon as we have an aneurysm and we continue to watch it, as soon as it starts to grow, I think there is an instability. If we want to continue to watch it, maybe okay, but I don't have the balls to do that. As soon as I see something unstable, I say maybe better we need to get rid of it. But if you observe one, it may be there for a while and it may stay stable and continue to stay stable. But as soon as they come, on our radar, I think if they start moving, we are a little worried. And maybe if we are getting more experienced, we will learn to trust more in our assessment, and maybe biological additional information like genomics or whatever will help us to decide and to be more brave. But currently, I'm brave, but not very brave. I'm very sorry.
I think we are discussing here is a good discussion because of the complexity of the disease. It's multifactorial, but there are elements. Daniel, for example, if you look at the mechanosensors in endothelium, they responded to shear stress. They don't respond to pressure. And that's one element. The other element, that in an aneurysm, there is a vascular unit that includes the artery before, the annulus, and the artery after. And if you have modifications in the arterial wall, you're going to have modifications in the shear stress in the aneurysm. And so when we follow an aneurysm, if there are changes in the anatomy or the geometry, there will be changes in the shear stress. And this is something which is totally unpredictable. So the size of an aneurysm is only a witness. It's only a witness, and this is the only thing that we're using now because we don't have anything else. And the flow biomechanical changes with time. You remove the elasticity of the artery, the wheel shear strength will change. You remove the angle of the wheel shear will change, and that is unpredictable. And the other concept is the answer is in the wall of the aneurysm. And this is the element that in the future, I guarantee to you, in the future, what I see from the biomolecular people, it will be possible using technology, imaging, what they call nanoimaginology, that you can use the imaging to identify the histology and the molecular biology of the wall of an aneurysm. That will be the answer. So we should continue to do what we're doing. Open the door and establish relationships with the so-called macrophysiologists today. They're working in bioengineering. That's what they're doing. They're doing in tumors. And the challenge we have, if you look at, try to, the 2D and the 3D utilization of tissue doesn't work because you don't have the physiology of it. So now they're going into 3D printing and biotechnology, trying to identify the wall. The wall of an aneurysm is the most difficult part of organ to put in an organ on a chip. And we should have a meeting in which at least we understand what people are doing, because that will be the answer. We should continue what we're doing. And this discussion will continue because the multiplicity and the complexity of the disease require more information.
Yes, I think we are dealing with a very complex, with a very complex disease, and we are trying to find very single answers sometimes during very long period of time. There are a lot of questions here, but I would like to, because we are approaching the end, we need some hope here. There is questions asking Daniel if you are aware or you think will be some drugs that will stabilize the factor of growing or the origin of the aneurysm. Are you aware of some drugs, or do you believe will be some drugs? What is your point of view about that?
This is a good question. I think we should offer, if possible, additional treatment to patients we only observe. The one who has most answers to this is David Hassan from Iowa. He has done a good job on understanding how aspirin, after he has reviewed the UCLA data, and I think he has done a good job. So with him, we learned that there is hope, but there will be different drugs, I think, coming. One drug we are looking at, not for aneurysms, but I think this may help in aneurysms too, is because it helps on inflammation and because it gives more energy at the cellular level, and it is developed in the US. It's called True Niagen. It's a drug I eat myself already for a year, always energy. And this energy is given to the mitochondria through nicotinamide riboside. It's this precursors of NAD, the stuff that makes energy and the energy for this at the cellular level. And I think this is what is driving inflammation in most of other diseases, is a lack of energy at the cellular level to maintain homeostasis at the cellular level. And this drug is just a food supplement, like many other food supplements. And I think that we will see things like that. So it may become a very simple thing acting at the mitochondrial or cellular level. It may be complex drugs, it may be, but I believe it may be expression of aging, of this capacity to maintain homeostasis at the vessel wall level. and maybe simple ways, as just I was saying, may be good. So aspirin for me is a drug that acts in a very basic way on many cellular mechanisms. And yes, I think there is hope. We just have not the money and not yet found the companies that do, and we just need to look along these lines. And since we start to identify a population we only observe, I think we should start investigating these options in addition, yes.
Are you using in your follow-up in your patients statins? Are you using the statins or other medication during the follow-up?
No, not. There, some patients get statins because they have atherosclerosis, but we unfortunately just don't have the currently the people to help us to control and do all this. I think the group that has mostly investigated in statins are the Japanese, and I'm sure that they will teach us soon more about the use of statins. And they also have investigated other drugs. So yes, you're very right. The Japanese will teach us more about unruptured aneurysms because they are observing quite a large population of patients with unruptured aneurysms.
Before I pass to our president, we are approaching the end. But just the last question: since we are in the inflammatory storm of COVID, do you think we will face more rupture aneurysm in our population that we follow very close? Do we must expect some more bleeding in that population because the COVID storm? What do you think?
Well, I don't understand much about COVID. I avoid it, so I don't claim to know much. But in my life, when I have seen dissecting aneurysms in the brain, it has been mainly after viral infection periods. So I can imagine that infectious diseases like COVID may, give us all the sudden observations on a weakness of the vessel wall. And usually if it happens in a segment of an artery, I believe there will be a dissection. And so the very bad young patient diseases, or also the long fusiform aneurysms I observe after, I today in my mind relate to dissection, maybe related to viral infections or periods of diseases where there has been organ manifestation, including the vessel wall. I don't know what will happen with COVID. Nobody knows what will happen. But yes, I think it's possible, yes.
Okay, Juan, you were raising your hand. Do you have a question for us?
No, it was a mistake, but sorry.
Pedro, the impacted of the COVID-19 in the endothelium is prothrombotic. It doesn't elicit, so far, it doesn't elicit, it does produce a prothrombotic because endothelial cell doesn't function, it produces a thrombus in sight, and so on, so on, so on. So, so far, there is no case that has seen aneurysmal formation because of COVID-19. It does, so far, there's no case. I bet you that in 1 million cases, in some cases will appear, oh, there is an aneurysmal dissection related to COVID-19, but the massive, the so-called cytokine storm produces a prothrombotic diffuse microthrombi and thrombosis, not aneurysm formation or aneurysm rupture. I mean, yeah, maybe he has a hypertension, but it's not related to the virus.
Okay. Manel, do you want to make a comment? Volvemos a vos. ¿Cómo ves el tiempo?
Bueno, si hay alguna cuestión más, ¿no? Si hay alguna cuestión más, podemos verlas. Yo creo que no hay ninguna cuestión más. ¿Tú ves alguna, Pedro?
No, yo creo que las hemos respondido todos. Yo creo que tenemos que agradecerle a Daniel y al team de Zurich el el trabajo que han hecho ha sido espectacular. Así que seguramente te dejo el cierre para vos. Muchas gracias.
Bueno, pues muchas gracias a todos. Muchas gracias, Daniel, por tu colaboración. Muchas gracias, Fernando, Juan y Polo. Y vamos a dar por finalizada esta convocatoria al espacio SILAN. Y nada más. Desearos feliz fin de semana a todos y os convocamos de nuevo al próximo viernes, que creo que estaremos con la Sociedad de Panamá. Muchas gracias a todos y feliz fin de semana.
Felicitaciones,
Chao.
Manu. Felicitaciones, Manu.
Gracias.
Saludos, Daniel.
Chao.
Chao a todos.
Pedro. Juan.
Thank you, Daniel.
Bye-bye.
See you around. Bye.
Oye,
Fuerte abrazo.
Polo, haz
¿Qué?
un poco de bicicleta, que te la acabamos de ver ahí atrás.
No, esta es eléctrica.
Es eléctrica, pero no anda sola. Bueno.
So Daniel, we're still friends, eh?
Yes, always.
I don't see any blood.
Good to see you, Daniel.
Bye-bye. Bye-bye.